Hopefully everyone's having a phenomenal Tuesday wherever you're joining from. But today we're very lucky to have with us Brittany, and she's going to be talking about some learnings from conducting sensitive research. So we'll go over a little bit about Pegasus for all of those who are unfamiliar or have never joined one of our meetings before. Brittany will then present, and we'll have time for some discussions and questions, and then some other ways that you can engage with Pegasus. So the Pegasus Institute, we focus on peace, global health, and sustainability, and operate under the values of compassion, equitable approaches, anti-oppression, anti-racist, and decolonizing approaches, respect, engagement, critical thinking, and tangible solutions. Most of our work involves interactive events such as this one, educational activities, publications of information, research, policy, and advocacy work. So I'm going to jump a slide ahead and we'll go back. So for all those who are unfamiliar, this is technically a part of our Emerging Leaders Network. We have a few other networks. We have the Francophone Network and the Latin American Network, as well as a mentorship program, a refugee health professional mentorship program, this webinar series, McGill summer courses, and lots of other ways to get involved. So if you find our contact info on the side, feel free to give us a follow or ever get in touch with any questions or any other opportunities that you'd be interested in. We'd love to have you. So we'll jump back and I'll introduce Brittany. So Brittany is a PhD student in public health sciences at the University of Waterloo with interests in aging, global health, and infectious disease. Currently, she is a co-investigator for a Pan-African research project and a board member for a nonprofit organization that supports older persons and their dependents in Uganda and Ethiopia. In 2019, she completed a BSc in health studies with a minor in gerontology, then took a year off to volunteer at a community health center in Uganda that aimed to improve the well-being of individuals living with HIV. Upon her return, she supported a clinical trial that aimed to improve advanced care planning practices for older Canadians. From these experiences, she knew that she wanted to support older individuals and that she was interested in the burden of infectious disease on this population. It was for this reason that she completed an MSc with a geriatrician as her supervisor. For her thesis, she led an international project with a community partner in Uganda, which aimed to improve care practices for older persons living with HIV. And for her PhD, she aims to expand this work in Africa to help promote a geriatric-friendly system of care across the continent. So I'll hand it over to Brittany. Thank you for joining us today.
Awesome. Thank you so much for that introduction. And I will be covering a lot of those things. I will be providing kind of a brief introduction of myself as well, but I appreciate you giving a good overview before I start. I'm just going to share my screen. So just let me know when you can see it. And then I'm just going to put it on presenter view. All right. Can you just see my main screen?
Yep.
Perfect. Okay, so good afternoon, everyone, and thank you for inviting me to present at today's webinar. I'm really excited to share with you my personal experience and learnings from conducting sensitive research internationally, particularly with vulnerable older adults in central Uganda. We will be having a question and answer period near the end of the presentation. I have a 30-minute time slot, so I'm going to try and get through all of my content. So if we could save the questions to the end, that would be fantastic. But please feel free to kind of write down questions if you have any thoughts throughout. So before I jump into the presentation, I wanted to start off by providing you with a little bit of information about me, so you have a basic understanding of sort of my positionality with respect to global health research and some of the content that we will cover today. So as was already stated, I am a PhD student in public health sciences, and I'm specializing in aging, health, and well-being. And my current research looks to see how we can improve and use data to better design health systems to improve care planning practices for vulnerable older adults. particularly those in low resource settings. I also hold a Bachelor of Science in Health Studies with a minor in Gerontology and a Master of Science in Public Health and Health Systems. And also am a current active board member for Reach One, Touch One Ministries, which is a community-based NGO that aims to improve the well-being of older adults and their dependents in both Uganda and Ethiopia. Also a co-investigator for one of the what was already mentioned, a Pan-African study, which I'll discuss a little bit later in the presentation. And importantly, I'm a current student member for the Interact Canada Research Group, which is a collaborative network of international researchers that are committed to improving services for vulnerable populations through high-quality data, and also promoting evidence-informed clinical practice and policy decisions. So just to provide you with some information on my history and kind of how I got to be where I am today, because I think it's important, especially as we talk about global health and when you're thinking about your career and kind of moving forward in this field, it's hard to kind of grasp where you're going and where you want to be. So as a whole, I've always kind of been passionate about improving care practices and the overall well-being of vulnerable groups. And this started out with me working primarily with children and persons living with disabilities, and more recently has shifted towards older adults and those living with and affected by HIV. So I really started my journey about 10 years ago during my undergraduate degree, where I had the opportunity to participate in an international service learning experience through St. Jerome's University. And then I went on to work and volunteer with numerous nonprofits in the region, some of which you can see listed on the slide here. So upon graduating from my undergraduate degree, I wasn't really sure what I wanted to do in terms of my career, but I knew that I wanted to learn more about various global health challenges and to really see where I could make a difference in some capacity. So I did spend several months living and working at the Reach Out Mabuya Community Health Initiative in Uganda, which is a community-based NGO, and they aim to improve quality of life for those living with and affected by HIV. And this role is really where I was introduced to the field of international development, and it provided me with a really strong sort of understanding of the intersections of poverty, gender, and HIV. So I began thinking more comprehensively about all of these different factors. And then once I came back from Uganda, I actually completed a post-degree Bachelor of Science on the ethnography of HIV to start exploring the impact of infectious disease on vulnerable groups at a more international level. And then at the same time is where I worked as a research assistant for a clinical trial that looked at improving care planning practices or advanced care planning for older adults in Canadian long-term care settings. And this is where I was introduced to my current supervisor, Dr. George Heckman, who is a geriatrician by training and was the primary investigator for Ontario. So as a result of all of these different experiences, I began thinking really critically about the effect of HIV on older persons in Uganda, as well as its implications for care planning. And it was this in addition to the partnership that I'd already developed with stakeholders in Uganda, that was the major driving force for me enrolling into the Master of Science program at the university. And I'll be sharing with you a little bit about the project that I completed for my degree a little bit later. So that was a pretty long introduction to me and what brought me here today, but I think it's important that you have an understanding of my experiences and how I'm actually able to talk about and have conversations about these topics. And also just to know where I'm coming from in terms of my perspective and my opinion on a lot of these different factors. So as I mentioned earlier, my research currently involves looking at how we can use data to better design health systems and improve care planning for vulnerable populations, particularly those in low resource settings. So specifically in my work, I use inter-eye comprehensive assessment and screening systems. And so today I'll be introducing you to kind of the basic structure of these tools and how we can use the information that we gather from these systems to better support health decision-making for vulnerable groups, both in Canada and internationally. And then I'll move into sharing some of my own research and how I used one of these tools in particular to support care planning for older adults in the Ugandan context. Okay, so before I discuss the Inter-I approach to obtaining comprehensive data, it is important to first understand why we need this information in the first place. So data is important in healthcare for several reasons. The first and probably the most obvious is to understand the patient and their current needs and experiences. But data is also needed to help guide diagnosis and management of health conditions. And it can also aid clinicians in measuring changes, progress, and outcomes in their patients. But we also need comprehensive data at the system level. So this is used to measure quality of care in different healthcare settings, to plan healthcare services by allocating resources and building appropriate infrastructure. And then also, data can be used to support system integration across various healthcare settings. So all of this is relevant in terms of discussing my research and why that is important. So now that we know why data is so important, I do want to introduce you to a reliable and comprehensive model for obtaining this information, which has been adopted internationally and across Canada more specifically. So Inter-I is an international not-for-profit network of researchers, scientists, and healthcare practitioners across over 35 countries worldwide. So this network develops instruments which provide a comprehensive assessment of the strengths, preferences, and also the needs of vulnerable groups in different healthcare settings. So just to give you an example, instruments have been developed for both the home care and the long-term care settings, which provide health information on vulnerable older adults. And so these assessments gather information on things like participant demographics, thinking and cognition, basic and instrumental activities of daily living, just to name a few, as well as several other relevant factors to these populations. So overall, the Inter-I model for comprehensive assessment involves multinational collaborative research to develop, implement, and also refine instruments and their applications so that we can better support care for vulnerable groups. And it also represents a standardized system which is interoperable to promote continuity across care settings. So it really allows for those conversations to happen between different environments and across assessments. And that can really limit assessment redundancy as well, which is a current problem, especially for our geriatric population. So each of the Inter-I instruments or assessments has several key different elements. So each includes core items, which are important in all care settings. So these could be certain questions on, say, cognition or basic activities of daily living, like brushing your teeth or personal hygiene, walking, stuff like that, which are applicable to all populations. And then each of these core items have identical definitions, observation timeframes, and scoring across each of the different instruments or assessments. And that's what allows for comparison to occur across various care settings and also between assessments. So if an individual was to have an assessment done in, say, a long-term care home at one time point, and then 6 months later had a home care assessment done or something, or vice versa, those assessments might not be the same, but there would be comparisons that could be drawn between them because of similar definitions, timeframes, and scoring. So it does allow for those conversations to happen. And then additional items are also included in each instrument, which are specific to care populations or settings. So as a whole, the sort of fully realized system contains obviously the data collection form, so the assessment, and a user manual so that you know how to actually pose the questions. And then upon completion of the assessment, we have triggers for clinical assessment protocols, status and outcome measures, quality indicators, and case mix algorithms. So in addition to the independent question responses, which are important, that information is very useful, but we also have a report that's produced that contains all of this additional information and can enable clinicians to make more informed decisions for their patients. So just to give you kind of a simple example, in the Ontario long-term care setting, upon an individual's admission into the home, they would have a long-term care assessment administered to them by a clinician. And then once that form was completed, various triggers, scales, quality indicators would be produced that could assist that individual and their team in developing a care plan for that patient and to monitor them over time through follow-up assessments. It's also important to note that while there are benefits to using these tools at an individual level, the data that we gather from these instruments can also be pooled, which can allow for both organization level and population level system planning. So it can be important for individual patients, but also for the system. And then just quickly here, each of the systems can be utilized by numerous stakeholders, including clinicians, which I briefly outlined previously in the last slide, service administrators, purchasing agencies, policymakers and planners, and then also, of course, researchers, as I'll get into a bit later in the presentation. And then just on this slide here, you can see a visual depiction of the widespread use of inter-eye instruments across Canada, where we have solid symbols representing instruments that are mandated or recommended by the government, and then hollow symbols where we have research currently underway. But also, in addition to Canada, we have the inter-eye model for comprehensive assessment and screening for vulnerable groups that's been adopted in over 35 countries worldwide. But despite this widespread use, there is a gap that's been identified among low and middle income countries, particularly in African regions. So research is needed to determine the acceptability of various inter-eye tools in these settings so that we can help promote their expansion and the improvement in care for particularly older adults, but among all vulnerable populations. Okay, so now that I've given you a really brief introduction to inter-eye and the use of these tools, I'm going to move into discussing some of my own research. So specifically, I'm going to share with you the second phase of the study that I completed for my master's thesis, which aimed to assess the acceptability of the inter-eye checkup self-report assessment with older adults in central Uganda. So as a result of demographic transition, Uganda is experiencing rapid population aging. And with this comes several health challenges, including chronic disease, disability, and also frailty. Older adults also often experience many additional challenges, which are unique to the Ugandan setting. And this includes acting as primary caregivers for grandchildren. They face a high burden of food insecurity, the erosion of social support systems, and also a higher rate of infectious diseases like HIV. And so all of these factors together sort of make it more difficult for older persons to maintain their overall health and well-being. And then to kind of tie it all together, the Ugandan healthcare system is currently facing important challenges in managing the emerging medical and social needs of this aging population. And this is due to insufficient healthcare resources, governance structures, and relevant health information systems. And so in order to slow the trajectory of the decline that kind of stems from population aging in this setting, we do need comprehensive monitoring through geriatric assessment and also timely intervention of healthcare services. So bringing this back to inter-eye, a promising strategy for low-income nations is the inter-eye checkup self-report. And this is a standardized, comprehensive geriatric assessment that provides clinically actionable information to address the care needs of community dwelling older adults. So specifically through embedded scales and algorithms, this assessment can be used to support decision-making in numerous areas like frailty, physical and cognitive function, health stability, mortality. And then this information, again, can also be pooled to help support care planning more broadly at the population level. The most notable factor, however, is that the checkup differs from most assessments and most inter-eye assessments, in fact, because it was designed to be administered by lay assessors or self-administered by patients. And this is really important, particularly for low-income countries like Uganda, where there is that lack of health human resources. So because of all of these factors, the checkup was shown to be a valuable low-cost solution, which could help to address not only individual level health challenges, but also potentially form the basis of a preliminary geriatric system of care across the country that's currently lacking. So as a result of these factors, this study aimed to assess the acceptability of the inter-eye checkup self-report with older adults in central Uganda. So I'm just going to go through the methods of this project. So the study was guided by the theoretical framework of acceptability, which was designed to assess healthcare, the acceptability of various healthcare interventions in different contexts. So it assesses specifically 7 different dimensions of acceptability for healthcare interventions. So affective attitude, so how an individual feels about an intervention, burden, ethicality, intervention coherence, how they feel that, or how well an individual can understand the intervention and its purpose, opportunity costs, perceived effectiveness, and then lastly, self-efficacy. So for this project specifically, acceptability was defined as a reflection of the extent to which healthcare providers delivering the checkup intervention considered it to be appropriate, and that was based on both experienced and projected responses to its implementation. So we needed folks to actually use the tool to be able to understand whether or not it would be acceptable to use at the organization. So this project was conducted in partnership with the Reach Out Mabuya Community Health Initiative, which I shared as a community-based NGO in central Uganda, specifically, which aims to reduce the spread of HIV and improve quality of life of vulnerable groups in their communities. And this also includes vulnerable older adults within their catchment area. So using a community-based care team of social workers and community health workers, Reach Out operates a comprehensive health program for older adults. And so this really was an ideal organization to assess acceptability of the intervention in central Uganda. So as I mentioned briefly at the beginning of the presentation, this partnership was developed through a placement, a volunteer placement that I completed with them back in 2019. So through living and working with Reach Out for an extended period of time, I was really able to develop strong relationships with key members of the organization's team, including a close personal friend who happened to be the monitoring and evaluation manager for the organization. So through numerous conversations with the community, I was really able to learn more about the key challenges that they faced, including those with geriatric services. So specifically, the community identified a significant gap in health human resources, and they also identified a need for more comprehensive assessment data on the geriatric population, because they really weren't sure what this population looked like, and they wanted to be able to use information to be able to apply for funding so that they could provide needed services to older adults. So as a result, we were able to design a community-informed project to try and address some of these issues. So in terms of the research approach, this study represents the second phase of a larger research project conducted in central Uganda. So in the first phase, healthcare providers at Reach Out were trained to use the checkup intervention, and then they administered the tool to older adults in the community. And an analysis was also completed. I won't be talking about this today, but this analysis looked at the differences in various outcomes across persons living with and without HIV, because this was identified as an area that Reach Out wanted to obtain more information on to see how older adults were impacted by this condition in the community. And then in phase 2, interviews were held with all of the providers who were involved in implementation of the assessment in the first phase, so that we could characterize acceptability of using the tool in this setting. So essentially, by having providers implement the checkup in phase 1, this really equipped them with the needed understanding and the skills to be able to evaluate the tool's acceptability for the Ugandan setting as a whole. So key stakeholders from Reach Out were identified at the beginning of phase 2 for participation in an interview. And this included project team leads, community health workers, and all of the other individuals who were involved in implementation of the tool in phase 1. And then once they were identified, each of the providers was recruited for an interview following the assessment of eligibility criteria, which you can see outlined on the slide here. So a semi-structured interview guide was developed, which was informed by the theoretical framework of acceptability, and interviews were held over Zoom and conducted or consisted of a series of close-ended questions to identify contextual factors, and then open-ended questions to assess participant perspectives surrounding checkup acceptability. And the reason that the interviews were conducted over Zoom was because this was in the middle of or nearing the end of the pandemic, so there were challenges with actually completing in-person data collection for this study. And then all of the interviews were transcribed and imported, and then data was analyzed using a deductive thematic approach, which was informed by the theoretical framework selected for the study. So in terms of results, 12 providers at Reach Out were interviewed as part of this study. 8 were female, and the average age was 39 years. And the sample was also mostly comprised of lay community health workers, and the remaining few worked as either social workers or in administrative positions. We included administrative roles as well, because we really wanted to be able to understand whether the tool would be acceptable from an administrative level as well. So it isn't enough to see whether, folks in the community could conduct the assessment, but we want to know whether there are any barriers at all levels of implementation. And then through qualitative analysis, acceptability was demonstrated for the assessment. So all of the study findings were positive for the dimensions of the framework, and they were consistent across provider disciplines. So on this slide, you can just see a few examples of quotes from the interviews, which aligned with some of the dimensions of the framework. But then in terms of more notable findings, there were additional findings through completion of interviews that are important to note. So minor gaps were identified in assessment components where questions could be added to better understand certain factors pertaining to the Ugandan context. Minor implementation barriers were also identified. So it was recommended that appropriate time and resources be allocated to support checkup use moving forward. But there was also a request for assessments to be offered in additional languages. So for this study, the assessment was offered in English, and it was also translated into the most relevant local language of Luganda. So the request for more languages really helped to demonstrate acceptability, because providers wanted to be able to improve their ability to use the tool and the community moving forward. Providers also did identify several benefits that they gained through using the tool. So this study also revealed kind of an opportunity for the checkup and accompanied training to be used to help improve the knowledge of geriatrics and care planning for older adults. And then lastly, gender differences across older persons were also found, which could help to provide insight for structuring assessors in the community, and then also for interpretation of data moving forward. In terms of study limitations, as participants in this project were recruited according to their affiliation with Reach Out, participant perspectives are not necessarily representative of the broader population of healthcare providers in this setting. And also, as the study took place in urban central Uganda, more research is also needed to assess acceptability in more rural areas of the country. And then finally, in terms of study implications, this research does have or has demonstrated that the checkup is an acceptable and useful strategy to address individual and system level geriatric health challenges in central Uganda. It also provided a high level of insight into how a standardized assessment tool can help support development of a more geriatric friendly system of care. And this was also an important step in establishing an inter-eye community of practice across African regions. And we also have important implications for future research. So I just wanted to briefly mention that the implementation of this project has spurred a larger initiative called the Pan-African Utilization of Lay Assessment Systems, or PALIS pilot project. So this project aims to assess the feasibility of deploying lay assessors to conduct comprehensive standardized assessments, particularly the inter-eye checkup, with older adults in low resource settings. So implementation has already begun in over 10 African nations, including Uganda, and we aim to continue to grow this project to provide additional evidence supporting the benefits of using these tools in these settings. And then I just thought I would end the presentation with a few things that I've learned from conducting research with communities, and particularly with organizations that I myself am not a part of. So I think the most important thing is really to first work on developing strong relationships and partnerships with communities before jumping into any sort of research project with them. And then really putting in the time and effort with communities on an ongoing basis to establish that trust and mutual understanding throughout the entire process. It's also really important to ensure, or try to ensure, that the project that you develop is community informed and community driven. So really what that means to me is that you're working alongside the community, facilitating open conversations, and really letting them speak for themselves in terms of what their needs are, and having them work with you throughout the entire process. So it really is a true partnership. You don't want it to just kind of be they provide information about what their needs are and you just take it and run with it. You want to work alongside and in partnership to make sure that the end goal and the end result is something that you can both be happy with and proud of, and that you can use that information for next steps. And then lastly, when working with communities, particularly internationally, I think it's really important to be flexible and to come prepared with the mindset that things will change and timelines will fluctuate. So that's something that I've had to learn. And I'm going to stop there just because I know I'm at the 30-minute mark. So that does bring me to the end of the presentation. So thank you everybody for listening. And I will stop sharing and we can move into questions or comments.